Hello, my name is Fong Yee and I'm an F1 in Queen Elizabeth Hospital. I worked in acute medicine, geriatrics, and now I'm on respiratory. So this is part of a series that's uploaded once a week until August, and today I'm going to talk about the role of F1 in night shifts. So in our hospital, we don't have F1 doing surgical night shifts. So today I'm just going to cover the medical side. Night shifts are definitely very tiring, especially on the first night. But I did enjoy night shifts a lot because in nights you don't have ward rounds. You don't need to do the tedious chasing, and that's because things that you deal with overnight that are important are actually urgent. So typically for night shifts, people would work through the day before the night shift, go to the night shift. When you're off the first night, you would go home, shower, have a breakfast, and then sleep until maybe 3 or 4 p.m. if you're lucky, and then go to the next night shift. And at the end of the night shift, people find it easier if they stay awake until the night time and wake up the next morning in the normal time so that you can easily transition to the normal day shift. Before you start the night, make sure you take a good handover from the day team, so that you have a job list and you'll be able to prioritize according to the list. Essential things that you need to bring for night shifts is your stethoscope, pen torch, pen and paper. Useful things that to bring along are your lunch, your phone charger, earphones, and a hoodie. I always bring a hoodie with me because it's quite cool at night, and sometimes when you are lucky and get a chance to rest, then you can have your hoodie and be warm when you're having a nap. So common bleeps are as below. So during the night time, other than the stuff that you're handing over, nursing staff would bleep you mostly when the patient is complaining of something, for example pain, or when they've got a high news score or one of the obs doesn't look right, or if the patient is not complaining anymore because they're dead. So let's go through one of them at a time. When you're answering bleeps, important things that you need to note is what they are bleeping you for. If you need to go into more details or it can't be settled over the phone, then you need to take the patient details, ask for the rest of the obs, maybe look at the patient notes or plus or minus review the patient. If you review the patient, then take a quick history, examine the patient, do the ABCDE approach and document it. Usually for documentation, unless it's very very mild things that you're dealing with, for example patient have a question for you, then I usually document it with the ABCDE approach. So I would say airway pattern, breathing is fine, SATs are this, cap refills fine, warm well perfused, blood pressure is this, and GCS 15 out of 15, and the rest of the examinations, investigations, and your management plan. And also it's a good practice to leave your name and the bleep number below so that people can bleep you again if there's another issue with the same patient or if they don't quite get the management plan. So first one that you always get bleeped about is for pain. So you always get bleeps about patient requesting analgesia. So if it's very mild symptoms or they're known to have, for example, abdominal pain, joint pain, and you know what the issue is, it's fair enough that you could up the analgesia. So if they haven't been given paracetamol, give paracetamol. If they have been giving paracetamol and it's still hurting, then go for maybe ibuprofen or cocodamol. Make sure there's no contraindications to all of this. So don't give paracetamol if they have acute liver failure or have been in a paracetamol overdose. Look out for history of ulcers, GI bleeding for NSAIDs, and any allergies for morphine, codeine. If the pain is new, then you will need to review the patient, do your Socrates, examine the patient. A good indication of severe pain is tachycardia, and if it's so severe that, for example, it's peritonitic in the abdomen, then you need to do further investigations and possibly refer the surgeons. But if it are some mild and specific pain, then you could usually trial some analgesia and review later. Chest pain. It's one of the very common things that you get bleeps about. So over the phone you would need to ask about the rest of the obs, obviously, if they're quite unstable with tachycardia, hypotension. You probably would like to involve a senior early, but if the obs are stable but the patient is having chest pain, then you'd ask the nurse to do an ECG whilst you're on the way to see the patient. So when you see the patient, do the Socrates, examine the patient heart, lungs and abdomen, and think about the differentials. So for cardiac chest pain, they are typically central crushing chest pain with maybe radiation to neck, jaw or left arm. Look out for back pain because it's important to rule out aortic dissection as well, but other differentials would include angina or ACS. If the patient is unstable with hypotension, shortness of breath, desaturation, then you might need to get the seniors involved, or if the patient is very, very unwell and they look like they're quite unstable and will deteriorate at any point, then put out a peri-arrest. If they're quite stable with the chest pain, then you would do your investigations, look at the ECG, do some drops and other bloods. And one thing that can help rule out aortic dissection is check the blood pressure from both arms, and if there's a significant difference, then it could indicate aortic dissection. Look for risk factors like high blood pressure, high cholesterol, smoking, obesity, diabetes, previous ischemic heart diseases and family history. And if it's quite convincing cardiac chest pain that's not aortic dissection, then you could discuss with your senior and start the ACS treatment. If you suspect aortic dissection, then definitely get a senior to review the patient and do not start the ACS treatment, because that could lead to worsening of the aortic dissection and the patient might bleed to death. You probably would need to do a chest X-ray, and if there's high suspicion of aortic dissection, you might just go straight to urgent CT angio and might need discussion with the cardiothoracic surgeon. Also, if it's high suspicion, then you would need to control the BP and allow permissive hypotension. Going on to pleuritic chest pain. It's usually worse on deep breath and coughing. Differentials include PE, pneumonia, pneumothorax, tension pneumothorax, and pleural effusion. Patient usually would have shortness of breath. Some would have tachycardia as well, and if they are in tension, they would have a deviated trachea. Pneumothorax would have reduced breath sounds and air entry on the affected side, and pleural effusion would have double percussion as well. You would typically hear some crackles in pneumonia, and PE you might not find anything on auscultation unless they have a massive PE and have right heart strain, which in turns you would have an elevated JVP, but that's quite unusual. So for risk factors for PE, history would include previous PE, DVT, evidence of PE in the patient, immobility, recent surgery, long distance travel, hypercoagulable state, which could include COVID, and pregnancy. So investigations that would help in this situation is ABG, chest X-ray, D-dimer, and other bloods including inflammatory markers, and consider CTPA if high suspicion of PE. If the patient is in tension pneumothorax, then before any of the investigation, you would do a needle decompression. If you're not comfortable with that, which I probably won't be comfortable with that, I would just fast bleep senior, or even put a peri-arrest call out for tension pneumothorax. I probably would just put a peri-arrest call out for that because it will need more medical attention than just an F1. For PE, if they're stable, they probably won't need a CTPA overnight. You could start them on treatment dose Clexane, but if they're unstable with it, for example, they're desaturating and has hypotension, tachycardia, then you would call for senior help, consider to do a CTPA, and they might be for consideration of thrombolysis as well. The rest, pneumothorax and pleural effusion, unless the patient is unstable with it, we usually don't do chest drain overnight or aspiration. So put a respiratory review out for the morning, and that should be sufficient. Moving on to GI causes, common differentials are reflux and peptic ulcers. So history would be retrosternal burning after food intake or before food intake. They typically would have a history of GORD or alcohol binge. Unless the patient is having a peritonitic abdomen or is vomiting blood or having melena, then there's no urgent investigation needed overnight. You could usually treat it with PPI and Gaviscon. But if you are suspecting perforated peptic ulcer or GI bleed, then you will need probably a senior opinion whether you need to start them on PPI infusion, whether they need, if they're having active GI bleed and losing HB, then you need at least a VVG and monitor the HB. If it's massive GI bleed, then it's a peri-arrest, and someone would need to come and do an urgent OGD. If they've got a peritonitic abdomen, then get an erect chest X-ray, do some bloods including grip and safe, and get a senior involved and probably refer to the surgeons. So desaturation, very common. Over the bleep you would get rest of the orbs. If it's just desaturation alone, then you would examine the heart, lungs, and fluid status. Check the target saturation, that's very important. I can't stress it more. It's in hospital, oxygen are given so commonly, but actually it could be very harmful for people who are at risk of CO2 retention. Make sure that they are not at risk of CO2 retention before you start them on oxygen, and document whether they should be on scale 1 or scale 2. Investigations include ABG, chest x-ray, bloods including D-dimers, full blood count, UNEs and CRP, and differentials include COVID, pneumonia, PE, pulmonary edema and ACS. Treatment would be according to the cause, so COVID there isn't much that you can do. Do a COVID swab. If they're desaturating a lot, then and therefore full resusc, then you might need an ITU review. Pneumonia, make sure that they're already on the right antibiotics. PE, you could consider starting them on treatment dose Clexane and CTPA. As I mentioned before, if the patient is unstable, then you need senior involvement, because they could be for thrombolysis. Pulmonary edema is a common cause of desaturation. They probably would have a history of heart failure or some kind of organ failure. Chest x-ray would be very helpful in this instance, and on auscultation you've probably hear bibasal crabs with pitting edema peripherally, and management for that would be diuretics, furosemide, if the blood pressure and renal function allows. And ACS is also a cause for desaturation, so that typically would come with chest pain, and you would do an ECG on top of all these investigations. So if you see a blood gas like the one on the right hand side, you would need to put out the peri-arrest cord and take the oxygen off. It's showing a decompensated type 2 respiratory failure with significant acidosis. The only good thing about this gas is the lactate is not high, but a saturation of 99% is not what you want to achieve in this patient, because the PO2 is more than enough and the PCO2 is very high. So this patient probably will need at least NIV, if not intubation and ventilation. So hypotension is a very common thing that you get bleeped about. I would say look at the trend of the blood pressure. There are people who usually runs on low blood pressure and they don't need any intervention for that, and especially for patients that are asymptomatic and chronically hypotensive and the rest of the ops are okay, so they're not decompensating, then you would be okay to just leave it like that. If it's an acute drop of blood pressure, make sure that the patient is stable enough for you to see them, so they're not crashing, being unresponsive and very tachycardic. If in that case, just ask them to put out a peri-arrest call. If they're slightly tachycardic, and the blood pressure is a bit low, then you would just go and see the patient, ask the nursing staff to lay the patient flat, elevate the legs, and give a bolus of 250, which is a very safe bolus, whilst you're on the way there. When you see the patient, do your ABCDE. If any of them are compromised, then put out a cardiac arrest call. But otherwise, you would listen to heart, lungs, abdomen, and check the fluid status of the patient. Investigations include ABG, chest x-ray, and bloods. Consider ECG, and if there's any abdominal findings, consider CT or abdo x-ray. Differentials include dehydration, which is very, very common, or any type of shock. So hypovolemic shock is quite common, septic shock is quite common. If it's hemorrhagic, then you'll need to put out a peri-arrest call and do a lot more blood tests, including grip and safe. Cardiogenic shock, I would get seniors involved as well, because in that case it's a balance of giving fluids and taking fluids off to help with cardiac function. Anaphylactic shock, put a peri-arrest call out. And neurogenic shock is quite unusual, but I would say if boluses are not working, then you need to get seniors involved. So management, you treat the underlying causes. With bolus fluids, I would give it depending on cardiac function. If the patient is not overloaded, then I would give boluses up to maybe 2 liters. If they have a poor cardiac function with a reduced ejection fraction, then I would give up to 1 liter. If it's slowly responsive, then you can continue with the boluses. If it's not responsive to your fluid boluses, then you need to consult your senior, and they might need ITU review. If they keep going down despite boluses, then I think either fast bleep the senior or put a peri-arrest call out. That's it. And for tachycardia, there's a very good algorithm that's available in the resus console. So as an F1, you would do anything on the green side and blue side. So basically, check the OBS, do your ABCDE, get the ECG, look for underlying causes. So things that are commonly causing tachycardia in hospital are septic driven fast AF, or anxiety, or hypovolemia, which are going into shock. So if the patient is showing any signs of adverse features such as shock, syncope, MI, which is chest pain, or heart failure, which they might be going into pulmonary edema, then put a peri-arrest call out and get people to come here. They might need anticoagulation and anesthesia for DC shocks. If they're stable and have a broad complex tachycardia, then put a peri-arrest call out, and they will need further management, either amiodarone or shock. If they have a narrow complex tachycardia and they're stable with it, then you have a bit of time to manage them yourself. Check the ECG. If it's irregularly irregular, then it's probably AF. You can, if it's sepsis driven, then you could try a bolus of fluids. If it doesn't help, then you can try them on beta blocker or diltiazem, depending on the past medical history. So avoid beta blocker if they have a history of asthma, COPD. Avoid diltiazem if they're already on the beta blocker. In case there's a regular narrow complex tachycardia, you could try the vagal maneuvers, so asking the patient to breathe out with a closed mouth, or ask them to squat down, or ask them to breathe out through a syringe. If it doesn't work, then and the tachycardia is persistently quite high, if it's 101, you probably can leave it for the evening and monitor it. But if it's persistently maybe over 120, then I would call for senior, because they might consider giving adenosine, and with adenosine you need a cardiac monitor, and that you can't manage alone as an F1. Otherwise, if the tachycardia is not settling with your intervention, then just seek senior support. Okay, so fever. It's quite common now with COVID. So if you get bleeps about a high temperature, check the rest of the OBS. Check when was the last time they had paracetamol, because you don't want to overdose them. And think about differentials. Most commonly they would be septic. So in that case you could give paracetamol and think about escalating antibiotics. Think about giving IV fluids to cool them down, or to replace the fluid lost through sweat. Think about other causes. So it could also be allergic reaction, sickle cell crisis, or other systemic illnesses. If it's an allergic reaction, then make sure that they're not in anaphylactic shock. In that case, you need to put a para-arrest call out and give adrenaline, IM. Common allergic reaction that you see at night are blood transfusion reaction. So if they happen to have a fever, a high temperature, when they are having blood transfusion, you would stop the blood transfusion, give them paracetamol, and make sure that monitor them for any shock reaction, so any swelling of the lips or tongue, or shortness of breath, or drop of blood pressure. If there isn't, then paracetamol would be sufficient, and hold the blood transfusion and make sure you document that and hand that over. Septic screen. So if the patient has a known source of sepsis and they're already on treatment of that, you probably can get away from just doing a blood culture and continue with the antibiotics. But if they have been well so far and they don't have a source of infection, then you need to do the full septic screen. And if there's no obvious source of infection, then you just start them on empirical antibiotics. If they're already on antibiotics for 48 hours and they haven't been spiking before and now they've spiked overnight, then you might consider escalating the antibiotics. And if on top of that they're hemodynamically unstable, then you might need a call to the microbiology to decide what antibiotics you escalate into. Okay, unresponsiveness. It's one of the very vague things that you get bleeps about, but can be very serious. So there are different levels of consciousness. If the patient during night is only responsive to voice, then maybe they're just sleeping and they're trying to sleep. But if the patient is unresponsive to pain or unresponsive to anything, then make sure that they have a spontaneous breathing and a pulse. If they don't have any of that, then put out a cardiac arrest call. But otherwise, go review the patient, check the OBS, do the ABCDE, check the GCS, try and think, why is this patient unresponsive, because there's so many differentials. But main thing that you need to rule out is stroke, intracranial hemorrhage, and any type of shock. I always check the target saturation because type 2 respiratory failure is so easy to happen in the hospital. and it can also present as unresponsiveness as well. I remember there was once when I was bleeped overnight about a patient who doesn't look right, but they couldn't tell me what's wrong with the patient. The obs are pretty fine. The news is just quite low. It's scoring just because of the alertness. But when I check the post-medical history, I find out that this patient is high risk of CO2 retention, and target saturation should be 88 to 92, when the saturation is actually 98% on 5 liters. So I asked them to turn down the oxygen. I went to see the patient, did an ABG, found out that the patient is acidotic and in type 2 respiratory failure, and put a peri-arrest call out. So this patient ended up needing NIV. So there's so many differentials in unresponsiveness that I would just review the patient and do some investigations. ABG, ECG, bloods, consider CT head are the minimum that I would do for people who had a drop of consciousness. So death verification, it's one of the very common things that you need to do as a F1. So this is exactly how I would document death verification, and that's exactly what I would do as well. So check their identity, check if they're responsive at all, put your stethoscope on the chest, listen for heart sounds and breath sounds, check for any carotid or central pulse, and check the pill pulse if it's reactive to light at all. Document the time of death very clearly, and document your name, role, and GMC number. So ultrasound guided cannulation, it's one of the most useful things that I've learned as an F1, and it's very useful during nights because there's so much less senior support during night time, and your SHO and reg would be so busy that if you are able to do the difficult cannulation or venipuncture, that will be very, very helpful. So in terms of indication, it will be difficult venipuncture, cannulation, or even ABG. Contraindications are the usual for venipuncture, so avoid the fistulas, be cautious about any place with injury, infection, or burns, but if that's the only place, then you have to go for it. If they have lymphedema or lymph node clearance in that limb, try to avoid that one if you can. Before you proceed with the difficult ultrasound, cannulation, or venipuncture, check the indication for it, because sometimes you can get away with changing things into oral. If they're only on IV paracetamol and they can swallow, then you can just change the prescription to oral and save the patient another stab in the limb. So complications of ultrasound guided cannulation is similar to normal cannulation, so it's quite rare, but worth mentioning any type of nerve injury or arterial cannulation. We'll tell you how to differentiate between the artery and vein later so that we can avoid that complication. Equipment wise, make sure you have an ultrasound machine, the cannulation set, sterile gel, and lots of wipes. So just to remind you of the anatomy, for ultrasound guided cannulation, you usually go for the larger veins. So the cephalic vein or basilic vein is a good place to go for. Median cubital vein is good for getting bloods from, but because it's where the elbow is, cannulas usually kink or stop working after a while if you put it there. Also, identify the artery when you're looking for veins as well, so that you know where to avoid. So vein versus artery, there are different ways that you can tell them apart. First is like the photo on the right hand side. Veins, when you put pressure on the probe, the vein would collapse where the artery wouldn't, and you can see the artery pulsating on the ultrasound as well. You can use color Doppler if you really want to. The artery would be red and the vein would be blue. And when you go with the cannulation, you can take some blood sample and run a blood gas, and that could tell you whether it's a vein or an artery as well. So there's two different ways that you can use the ultrasound probe. One is transverse and the other one is longitudinal. The advantage of transverse is you can see the center of the needle in the middle of the vessel, but then you can't see the whole needle in the vessel, and that's exactly the advantage of longitudinal approach, where you can see the entire needle throughout the procedure, and you can see the tip of the needle, whether it's actually in the vein or not. The best thing is you use both of them, and you can make sure the needle is inside the vein and the tip of the needle is also inside the vein. So when you're inserted, you hold your ultrasound probe with your non-dominant hand. Check the probe orientation, so you can tap it with your finger on each side of the probe to find out whether it's on the right or left. Then put it onto the arm. Align the middle of the probe to the middle of the vein. Insert your needle at midpoint, 45 degrees to the skin. So these larger veins are usually deeper, so rather than going quite shallow, usually you need to go more acute, so 45 degrees is usually fine. Find the needle tip and progress slowly throughout. You can use a fanning maneuver, which is just to angle the probe back and forth to help find the needle tip. And when you're in the transverse mode, you'll see the bullseye sign, which is the needle within the vein. And on transverse, you would see the shaft of the needle and the tip of the needle inside the vein. And also, if it's in, you'll see the flashback, and when you flush it, you can see a whoosh of fluid going in as well on the ultrasound. So, next tips. Ensure you clean the gel before applying dressing, because the gel is very slippery and the dressing will just come off if you don't clean it properly, and that's what you don't want to happen when it's a difficult cannulation. So get a few alcohol wipes, wipe away all the gel, make sure it's clean and dry before applying a dressing, and secure it with bandages so that it doesn't come off. Use at least a pink or green cannula, because that means it's also longer, and because the veins, the larger veins are deeper, you need a longer needle to reach it. The last thing you want to happen is using a blue needle that you've just reached the vein but unable to advance further because it's too short. It's always helpful to have someone to assist you on the side, because you've got the ultrasound probe on one hand and the cannula on the other hand, and it's very helpful if there's someone who can hand you or help you do the flush and do the dressing as well. So that's the end of the presentation. Hope you enjoyed that, and have a good day.